Picking up where we left off in class, I believe this is around slide 54. Before just jumping back in here, why are we talking about resistance? Because it's one of the three factors that affect blood pressure. So we have resistance is one. We are going to talk about cardiac output, and actually we discussed that pretty thoroughly with the heart, as well as blood volume, the amount of blood that's actually in the body. So with resistance, we previously were talking about how the blood vessel's diameter, if it's a large diameter versus, sorry, it looks the same, versus a smaller diameter, how that affects the resistance. Obviously, the smaller the diameter, the greater the resistance. We also talked about the thicker the blood, the greater the resistance. And now we're talking about the length of the blood vessel. So the longer the blood vessel, if this is the normal length of it, if it gets lengthened, you have to have a greater resistance, more pressure to push the same amount of blood through a longer vessel. Think about if you have a really short hose versus a very long hose. That long hose, the water's not going to come out as powerful. So when would a person possibly increase vessel length? That's with increased body mass, whether it's fat or muscle. On average, they say about a pound has about a mile of capillaries in it. So it's a mile more capillaries for each pound that your heart's having to pump blood through. Okay, again, we talked about this with the heart, just kind of reviewing that cardiac output is the product of stroke volume, which is how much blood is ejected or pumped per beat, and heart rate, how many beats per minute. That equals cardiac output. So, of course, cardiac output is going to affect blood pressure. The greater the cardiac output, the greater the blood pressure. So cardiac output and peripheral resistance are two factors that determine a pressure gradient. Again, we know that blood is going to move from high pressure to low pressure, always. And so the heart and vessels must maintain this pressure gradient. So pressure, therefore, the change of pressure is equal to cardiac output times the peripheral resistance, or total peripheral resistance. So again, when cardiac output increases, when the heart's able to pump more blood per minute, obviously blood pressure would increase. If peripheral resistance increases, let's say you're adding more weight to the person's body, they're gaining weight, then that's going to increase the blood pressure as well. So again, the final factors, we have resistance, we have cardiac output. The final thing is the amount of blood in the body. So the total amount of blood in the body is directly linked to how much water is in our blood. Remember that blood is typically about 90 to 92% water, or of the plasma, sorry. Plasma is 55% of blood. So out of the plasma, 90 to 92% of that is water. So when blood contains more water, person's well hydrated, then the amount of blood in the body increases. And whenever blood volume increases, that has a direct relationship with blood pressure. Blood pressure will increase as well. So if you're losing more water, meaning urinating more or possibly dehydrated, you're going to have a lower blood volume, and that will lower the blood pressure. If you add a lot of water to the body, then you're going to increase the blood volume and therefore increase the blood pressure. Small increases in blood volume are offset by the fact that, remember, our vessels have a lot of elastic fibers in them that allow them to stretch, and their ability to stretch is called compliance. Veins are the vessels that are the easiest to stretch and accommodate added fluid. with only a small rise in pressure. That's important, only a small rise. And a big reason for that is because, again, they are the capitance vessels. They're the blood reservoirs. So when the arteries harden, we talked about atherosclerosis, this decreases the body's ability to have adequate blood flow. So blood flow becomes turbulent. Basically, it's not smoothed whenever you have the plaques, and so you're going to decrease the amount of blood that's able to go to tissues further down the blood supply. Okay, so these are all the factors, again, that determine blood pressure. This is a great slide to recap what the previous slides, several slides, talked about. So this is a really important one. I would make sure that you understand how, for example, vessel length affects peripheral resistance, and therefore what's the effect of blood pressure. You should know if I have questions on either of any of these factors. So great place to review, talk yourself through, make sure you understand. If you feel like, I know that's kind of a lot of information at once, this is a really great video that will help review some of that material for you as well. Okay, so blood pressure, talking about in different parts of the body. So we're talking about the pulmonary circuit. The blood pressure should really not change that much, near as much as it does in the systemic circuit. And why? That's because the demands of the body are going to have a greater effect on organs of the systemic circuit versus the pulmonary. Blood pressure and the two circuits are dramatically different. And again, that's basically why the left side of the heart has to be thicker. It has to pump against a greater resistance. It does not pump out more blood per beat, but it does have a greater resistance for which it has to pump. The average is about 15 millimeters of mercury in the pulmonary circuit, much higher in the systemic circuit, almost 100, 95 millimeters of mercury in the systemic. Remember, the left ventricle pumps blood into the systemic circuit, the right ventricle pumps blood into the pulmonary. So again, it doesn't need to be as thick. So systemic arterial pressure, typically we're talking about someone has a high blood pressure. Of course, this is what we're referring to. And this is going to be the highest in the aorta, okay, the first vessel that blood is forced into when the heart contracts. However, this is pretty hard to measure at that level. So typically we're actually going to measure it in the brachial artery. So the further we move away from the heart, the less the pressure, since the heart is itself the pump. So this is a really important term that you need to know. Mean arterial pressure is the mean is average pressure in systemic arteries during an entire cardiac cycle. So you're taking into account both systole, contraction of the ventricles, as well as diastole, relaxation. Again, as I previously mentioned, the mean arterial pressure should be held at 95 millimeters of mercury in systemic arteries. So of course, we've previously discussed the heart. We understand that, and again, what determines systemic arterial pressure is the ventricles. So we're talking about the ventricles here. The ventricles are going to go through contraction and relaxation. So of course, when it's contracting systole, the pressure is going to be higher, it's going to rise. When it's in diastole relaxation, it's going to decline. So typically when you're given a blood pressure, you're actually going to see two values. So the top number is representing during systole, the bottom number is in diastole. Again, the mean arterial pressure is taking into account both of these values. So systolic pressure, and this is why I use those numbers, this is average, about 120 millimeters of mercury when the ventricles are in systole, and 80 millimeters of mercury in diastole. And this is when the person is at rest, which that's very important. The difference between the two is known as pulse pressure. So literally you just take 120 and you subtract 80. So in this example, my pulse pressure would equal 40 millimeters of mercury. When we're talking about the pressure of blood, you have to include those units. They will always be the same. We measure blood pressure using an instrument called a sphygmomanometer. That's going to help basically block off blood flow to the vessel. Then you can slowly allow blood to come back in. And as this happens, using a stethoscope, you can hear blood flow return and you're able to calculate someone's blood pressure. We will go through the steps of this in lab. So again, MAP itself is hard to measure. So we have an equation that basically gives us the best representation of this. So we're going to take the pressure when the heart is at rest, the ventricles are relaxed, and we're going to take a third of the pulse pressure, which again is, remember, the difference between the two values. So that's how you're getting that 95. We're basically taking, assuming again, the 120 over 80. So we're taking 80, and we're going to add that to a third of 40. Add the two values together, that's about 95 millimeters of mercury. So systemic capillary pressure, we're looking at the arterial end. So as blood is first entering the capillary bed, that's going to be higher than it is on the venule side. So it's about the same as it is as small arterioles, which directly feed the capillary beds. That's going to be about 35 millimeters of mercury. On the venule end, so where we're draining, picking up metabolic waste from the nearby tissues, the pressure has decreased to about 15 millimeters of mercury. So how did this pressure get reduced? It's mainly reduced because this fluid is being forced out of the capillary bed and into the fluid surrounding the cells. It's what we call filtration, and we're going to talk about that more specifically later. Pressure declines further as the venules dump into veins. So by the time blood has left the last venule of the capillary bed, the pressure is about 15 millimeters of mercury. The superior inferior vena cava, it would drop to about 4 millimeters of mercury. You have no pressure by the time it's in the right atrium. And of course, that's because the right atrium can contract, therefore reinstating that pressure gradient. So why do we have a low pressure? That's mainly due to the fact that these vessels have a high compliance. They can easily stretch. And also because they have less resistance, because here you're going from smaller blood vessels to larger and larger, versus in arteries, we're obviously moving from larger to smaller, therefore increasing peripheral resistance. So in veins, as we move closer to the heart, peripheral resistance greatly decreases. Venous blood, or venous return, is basically the amount of blood that's returned to the heart. So this must be returned at the same rate that the heart then pumps it into the arteries as the blood leaves the heart. So there needs to be something else that's going to help the venous circuit ensure that the venous return is what it should be. If you want the heart to pump more blood out, you have to increase the amount of blood going to it. So there's nothing really to propel. Again, we don't have a pump like the heart. So what do we have that can help with this? And we're going to talk about that. This is basically just giving you kind of a comparison of the different vessels. The only ones that you need to know specifically, really, I want you to know, we talked about these values, the 120 and 80 in arteries. The smallest arterioles, really not knowing they're 35. You need to know the capillary. We're going to get a lot more in depth with these relationships and the fact venules, really just veins, especially the vena cava, can be close to zero. Okay, this is showing the mean arterial pressure. So we're starting closest to the heart. Okay, so the first elastic vessel which leaves the heart is the aorta, okay, with its branches. So the three branches of the aorta are your elastic arteries. Muscular distributing are going to be examples like brachial, femoral. The smaller arterioles, of course, capillaries. So you'll notice as we move, as we're close to the heart, we have a big difference between when the ventricles are in systole, contracting, versus when they're relaxing. So the further that we move away from the heart, the less you have a difference in pressure. Okay, to the point, by the time you get to the arterioles, there really is not a difference between when the ventricles are in systole versus diastole. And you'll notice, of course, as you continue down, you're not going to see that pressure gradient because, again, you don't have the pump. Notice, of course, that the pressure continues to drop, and that's a big reason because capillaries are very small, resistance increases, so that's going to cause the blood to slow down and flow, which drops the blood pressure. And then venules, veins, and the large vena cava have very large lumens. So the peripheral resistance has decreased, which continues to lower blood pressure. So how does blood flow overcome gravity if there's hardly any pressure behind it? Specifically, really, we're talking about, of course, when one's standing up. Okay, how can we get all the blood here with hardly any pressure all the way back up to the heart? So smooth muscle within the vein walls contracts when the sympathetic nervous system is stimulated. So that will increase venous return. Sympathetic, you need to exercise, which means you need to increase cardiac output. If I want to increase the amount of blood the heart's pumping out, then I need to increase the amount of blood that it's receiving, which of course is the venous return. The skeletal muscle pumps. These surround the deep veins, and it's very important in the upper and lower limbs because those are what are fighting gravity the most and where we have the most skeletal muscle, obviously. When they contract, they squeeze these vessels nearby and they basically force the blood upward. Remember that veins have valves that will help prevent the backflow. So we ensure that when it squeezes, we're moving still in that upward motion. Okay, so you have relaxation. Squeezing is going to force the pressure, forces blood upward. So if some blood gets forced downward because of the valve, it can't go any further down. So slowly you can basically have this milking action all the way up the leg, and that will help increase venous return. In the thoracic cavity and abdominal cavity, we have the respiratory pump. So skeletal is important with limbs. Major organs, we have the respiratory pump. So these are the pressure differences that you have in the thoracic and abdominal cavities while a person is breathing, which is what ventilation is. So when you're breathing air in, inspiration, there's a high pressure in the abdominal pelvic cavity because the diaphragm is basically forcing down. And this pushes blood that's in those abdominal veins upward. There's lower pressure in the thoracic cavity, so this allows these to expand, therefore holding more blood. When you breathe out, abdominal veins are able to expand and fill with blood, while then the thoracic veins are squeezed. So it basically creates this alternating filling and squeezing, therefore ensuring venous return. Okay, so when we are breathing in, the diaphragm is going to move down. Okay, that's going to increase the amount of pressure on the vessels in this area, therefore forcing blood upward. Whenever we breathe out, now you have less pressure here. These vessels can expand and blood could easily be returned to the heart. So again, it's this alternating breathing that's important in the respiratory pump. And again, that helps ensure venous return. So discussion question, why are valves more important in the veins and arms and legs than in veins that would be in the neck? And the reason for that is the arms and legs have the skeletal pump. The skeletal muscle pump is only working when a person's actually moving, contracting. You're always going to be breathing. So that's going to help with the other veins. Plus, neck veins, obviously, blood's going back towards the heart, so it's going down. So you're not fighting gravity either. So the three mechanisms that would help maintain venous return in the arms and legs, we have the respiratory pump, the skeletal muscle pump, and then the actual contraction of the smooth muscle of the vessel wall itself. Briefly mentioned this in class and lecture. Varicose veins is a very common condition in which, because of constant overstretching, that a person's veins become enlarged, overstretched, so that the valves no longer create a stoppage of blood flow. Therefore, blood can backflow. Most often we see these in the lower limbs, superficial, so you can see these easily through the skin. So if you can't prevent backflow, that means that venous return is going to be decreased, which means that cardiac output will be decreased. We really see this during pregnancy, standing straight for a long period of time. Moving is very different. If you're obese, specifically holding a lot of extra weight in the abdominal area, all of these are going to increase the amount of blood that basically stays, or we call pools, in the lower limbs. So again, that decreases the venous return. So some of it is from overweight standing. Other parts are genetic. Unfortunately, in the superficial veins, so the deep veins, that is the skeletal muscle surrounded by skeletal muscle, so that pumps. But these superficial ones that you can see do not have skeletal muscle around them. So it's easier for them to get stretched. And therefore, again, the valves cannot close properly and backflow occurs. So when valves can't close, we call that incompetence. So these are just some pictures that help show varicose veins versus spider. So again, an healthy valve, the valve can completely close, therefore not allowing blood to backflow. That's not going to happen. In varicose veins, you have bulging areas, and so the valves are becoming incompetent. They're unable to prevent backflow. And you can see, because these are superficial, of course, you can see the bulges, superficially through the skin. Spider veins are different. Spider veins, you don't see the stretching, so you don't have the bulging like you do with varicose veins. Basically, essentially, it's the same idea. The bulging that occurs in varicose veins, when that occurs in the anal cavity, that creates hemorrhoids. So whenever you have increased pressure through either defecation or childbirth, that decreases the amount of blood that can be removed from the anal veins. So the same idea, they start bulging and stretching, and they start becoming more dilated. Pulse points are areas on the body where you can feel, we call palpate, superficially through the skin. And because blood in arteries has a pulsing nature to it, because of ventricular systole and ventricular diastole, you can feel this on some of these superficial arteries. So specific areas we refer to as pulse points, and therefore we can use this to assess if the heart rate is low or high and how the blood flow is. So when the ventricles are contracting, obviously the arteries are going to expand. When the ventricles are relaxed, they're going to recoil. So that's what creates that pulse. So since one pulse occurs each time the heart beats, then if you count the number of pulsations that you have underneath that artery, then you can calculate the heart rate. One of the most common pulse points is the common artery pulse point, which of course is just to the side of the neck. It's one of the easiest to assess this information because it's closest to the heart. So specific pulse points will be discussed in lab. Again, the easiest to take it's carotid pulse. A lot of nurses very commonly will do radial pulse as well, but all of these are different pulse points. So to review, if we look at the change in peripheral resistance as the blood vessel diameter increases. So if it starts smaller and gets larger, that means it's not going to be squeezing on the blood as much, which means the peripheral resistance is decreasing. Which of the following is not true of hemodynamics, the way that blood flows through our vessels? So systolic blood pressure is the highest pressure in the artery. Yes, that's true. That's when the ventricles are contracting. If you increase the lumen size, that will decrease the peripheral resistance, therefore increasing blood flow. That is also true. Total peripheral resistance is controlled by arterioles. That is true. When they contract, you increase peripheral resistance. When the smooth muscle relaxes, peripheral resistance is decreased. If you make the lumen of the diameter smaller, that would increase blood pressure, not decrease. So of course that's our false statement. And diastole, which is during relaxation, is the time between heartbeats. That's true. That's when the heart's filling with blood. Okay, which of the following is not considered a factor in vascular resistance? So the longer the blood vessel, the increased peripheral resistance. That's true. The thicker the blood, the more increase the peripheral resistance. That's true. The size of the diameter, as we just discussed, the smaller the diameter, the greater the peripheral resistance. So that's definitely a factor. Brainstem control over peripheral resistance. So basically sympathetic stimulation causing the arterioles to contract, which would increase peripheral resistance. That's true. pH of blood. The acidity of blood has nothing to do with vascular resistance. Okay, so we're looking at which statement is not true of venous return to the heart. So an incompetent tricuspid valve. So this is the valve between your right atrium and left ventricle. This means that it's not closing properly. We're saying that would decrease the venous return. Well, if it doesn't close all the way, that means during ventricular contraction, not as much blood is ejected, which means that cardiac output would be decreased. So naturally, venous return would be decreased as well. Must be the same as the amount of blood pumped into the arteries from the left ventricle. That is true. Blood from the right side of the heart gets pumped into the pulmonary circuit. Blood from the left side of the heart gets pumped into the systemic. The amount of blood is equal. Always. However, remember the left ventricle is thicker because it must overcome a greater pressure. It's that greater peripheral resistance. Respiratory pump increases venous return to the left atrium. That is our false statement here. Why? Respiratory, anything that's a pump aiding venous return specifically, means it's going to be to the first part of the heart, the right side. So that should be the right atrium. The speed or velocity that blood slows as the cross-sectional area of vessel decreases. That's false. If you think about a large vessel versus several smaller, okay, we know that blood flow is going to be faster in this large vessel, and it's going to slow down because of an increased peripheral resistance in the smaller. Which of the following statements is true? This is looking at blood pressure. Pulse pressure is the difference between diastolic and systolic, so that's true. Korotkoff sounds are the closing of the atrioventricular valves. I specifically haven't talked about this in lab, we will. Korotkoff sounds are what you hear when taking blood pressure. That's the sound of blood returning back through the brachial artery, excuse me. However, you would still know this is false because remember when the atrioventricular valves close, that's going to be the heart sound. That's our S1 or the lub. Diastolic pressure is the pressure on a vessel wall during ventricular contraction. That should be relaxation, so that's false. Sphygmomanometer is the instrument we use to listen to blood pressure, not heart sounds. Heart sounds, we would use a stethoscope. And the radial artery is compressed during measurement of blood pressure. Not to get blood pressure. If we compress it, that's to get the heart rate. That's our pulse point.